Hello everyone. Assalamu alaikum. I'm going to talk today about the acid-base changes in DKA. We'll talk about the pathophysiology. We'll talk about the impact of the treatment on the acid base. We'll mention some facts about DKA, and we'll talk about some important clinical and practical points. Okay, let me start with this. Normally, insulin will promote the uptake of the glucose by the skeletal muscles and the peripheral tissues. Also, insulin normally will inhibit the glucagon production by inhibiting the alpha cells of the pancreas. Okay, what would happen if you have low insulin? That will impair the uptake of the glucose by the peripheral cells. The glucose will stay outside the cells, and that will result in hyperglycemia. Low insulin will result in high production of glucagon. What is the effect of glucagon on glucose? Glucagon has two main things to do. Number one, it will increase the breakdown of glycogen in the liver. As we know, glucose is stored in the liver as glycogen. Glucagon will increase the breakdown of the storage and release the glucose into the blood. Glucagon also will stimulate the liver to produce glucose by utilizing unusual precursors like some amino acids, both of which will result in significant hyperglycemia. Now, what is the consequence of having hyperglycemia? Osmotic diuresis. You're going to lose significant amount of electrolytes and water, and that is why patients with DKA, they usually present with volume depletion. Okay, any other effects? Yes, insulin normally will inhibit breaking down of the fat, lipolysis. How? It inhibits the enzyme responsible for converting triglycerides to free fatty acids. Now, what would happen if you don't have insulin? Lipolysis won't stop, and as a result, you will have a lot of free fatty acids. Free fatty acids will be released into the blood and will be taken up by the liver, where it will be oxidized completely. However, because of the overproduced free fatty acids, a second utilization line will be activated. Free fatty acids will undergo several reactions and form keto acids. This is called ketogenesis. Okay. Again, under normal circumstances, insulin will slow and inhibit ketogenesis. If you don't have insulin, ketogenesis will just keep going. You will have significant amount of keto acids. What makes the things worse and even fast is the high glucagon. Glucagon will stimulate the ketogenesis. Okay, let me explain the things again from another perspective. Why we need glucose? Every cell needs glucose because glucose is the main fuel in our body that can provide the cells with energy. Without the energy, cells will die. You die. When glucose gets inside, it will undergo glycolysis uh, until it converted to pyruvate. Pyruvate will get inside the mitochondria of the cells and get converted to acetyl-CoA. Acetyl-CoA will enter the Krebs cycles, the product of which will interact with the electron transport chain. What is the end results of these things? Energy in the form of ATPs, water, and carbon dioxide that you're going to exhale. We call these products neutral end products because it won't change the acid base. Okay, what if you don't have glucose at the doorsteps, i.e., in starvation, for example? Our body should look for alternative fuel. How about amino acids? Amino acids can be catabolized to pyruvate, and pyruvate will follow the same path. However, brain cells won't be able to uptake amino acids. So we have to look for another alternative. The main alternative fuel in our body is fat. Breaking down of fat will result in free fatty acids. Free fatty acids, when get oxidized completely, it will form acetyl-CoA. I will ask you the same question again. Will the free fatty acids be able to get inside the brain cells? The answer is no. How about keto acids? Keto acids are derived from fat, but keto acids are water soluble. it can cross the blood-brain barrier and can get inside the brain cells easily. Keto acids will undergo several reactions and convert it to acetyl-CoA. Acetyl-CoA is the magic key here. All the roads lead to acetyl-CoA. It is the entry point into the Krebs cycle. Acetyl-CoA will be shunted into Krebs cycle. The product will interact with electron transport chain, and as a result, you will have energy. Okay. The idea of looking for alternative fuel sounds good, right? Well, that depends on whether you're dealing with physiological or pathological condition. Physiological, like starvation, where you don't have a problem in your body, but you have a problem in the environment around you. You don't have food, you can't eat carbs, you can't supply your body with glucose. While in pathological, like in DKA, you don't have a problem in the circumstances around. Your body is diseased. The problem is in your body. Okay, let me start over, and I'll start here with starvation to make the idea easy to understand. In starvation, the glucose will drop, and as a result, the beta cells of the pancreas will not sense the glucose, so it will decrease the production of insulin. And because of that, lipolysis will be stimulated and you will have free fatty acids. Please note that the drop in the glucose is slow and the drop in the insulin is slow, and the free fatty acids will be accumulated gradually. The free fatty acids will be taken up by the liver where ketogenesis will take place, right? And again, keto acid production and accumulation will happen gradually. Okay. Add to that the utilization of keto acids by the different cells in our body, especially the brain cells, is very effective. Now, do you think we have enough time for our body to adapt with that? Yes, indeed. The rate of utilization and metabolization will almost meet the rate of production. That's why the accumulated keto acids in starvation is low. And as a result, the degree of metabolic acidosis is mild, and the bicarbonate won't be less than 18. Okay, how about DKA? Well, in DKA, you will find yourself running out of insulin over few hours. Our body will try to look for alternative fuel, as glucose can't get inside the skeletal muscles and peripheral tissues. Lipolysis will get stimulated. Lipolysis. As a result, you will have high free fatty acids. Please note that glucose is high, but insulin is low. The free fatty acids, the alternative fuel, is high, but the main fuel is high too. These nonsense pathological reactions that we see in DKA. Free fatty acids will go and move to the liver, where ketogenesis will take place. A lot of free fatty acids there. And as a result, you will have a lot of keto acids. Add to that the utilization of keto acids by the brain, by the heart, by the kidney, by the skeletal muscles is impaired. So the high production and the decreased utilization, the end result is huge amount of keto acids. You will accumulate significant keto acids in 24, 48 hours time. The question is, will our body be able to handle this huge amount of keto acids? The answer is no. Indeed, you will 100% die if you were living before 1922, before insulin was discovered. Okay. Now, what are the ketone bodies that we have in DKA? The primary and the initial one is acetoacetic acid. Acetoacetic acid will be reduced to beta hydroxybutyric acid. This is the most predominant ketone bodies in DKA. Acetoacetic acid will also spontaneously decarboxylate into acetone. Acetone does not dissociate, and that's why it won't change the acid base. Acetone is mainly cleared by the lungs and ventilated out slowly. That's why DKA patient will smell like a fruit when they breathe out. Okay. Now, what would happen when you have added acids into your body? As I explained in a previous video, the main cation in our body is the sodium. The main anions are chloride, bicarbonate, and other anions that are present in small amounts. We're not interested in counting them, so we just put them all together and we call them anion gap. Anion gap concentration is 12 milliequivalent per liter. Okay, now what would happen when you have added acids into your body? Keto acids. Keto acids are strong acids. They gonna dissociate completely. Okay, uh, presence of hydrogen in the blood will lower the pH, causing significant metabolic acidosis. We have to do something. We have to buff this. The main extracellular buffer in our body is bicarbonate. Bicarbonate will step forward and bind to the hydrogen, trying to neutralizing the pH. That will form carboxylic acid. Carboxylic acid will be catalyzed by the effect of carbonic anhydrase enzyme into water and carbon dioxide. Okay. The keto acid anions will replace the uh, decomposed bicarbonate. Do we measure them? No, we don't measure them routinely. So we'll add them to the pool of the unmeasured anions. As a result, the anion gap will increase. You will have high anion gap metabolic acidosis. Why? Because of added keto acid anions. Okay. Now our body will try to get rid of some of the keto acid anions. So let's say that part of keto acid anions will be excreted in the urine, but as we know, it should always be accompanied by cations. Sodium will accompany the keto acid anions and will be excreted into the urine. That's why the urine is positive for ketones in DKA. Okay. Since the ketogenesis is ongoing, the lost keto acid anions will just be replaced easily. Now, how would this patient present to you? The patient will present feeling unwell, having vomiting and abdominal pain because of metabolic acidosis. The patient will be short of breath, cosmal breathing, as our body is trying to compensate for metabolic acidosis with washing out CO2. The blood pressure will be low, or the patient will have postural hypotension, tachycardia, the JVP is low or even invisible because of the significant volume depletion. Uh, you do the labs. Glucometer is high, urine dip, 4 plus ketones, 3 plus glucose. The ABG showed pH of 7.1. With bicarb of 8, we have metabolic acidosis with well compensated PCO2. Urea is high, creatinine is high. However, urea is higher in relation to the creatinine because of prerenal azotemia. Sodium is 140, chloride 104, and albumin of 42. Okay, now let's calculate the anion gap. The anion gap is 28. It is high anion gap metabolic acidosis. Okay, now what to do? We'll start the patient on IV fluid. We have to restore the circulation. We have to expand the intravascular volume. Okay, how about insulin? Will you give insulin? No, no, you can't give insulin without checking the potassium. 5% of DKA patients will present with hypokalemia. If you give insulin for those patients, you will shift the potassium inside the cells and you will make the hypokalemia worse and you're gonna induce cardiac arrhythmias and the patient die. Okay, so do not start insulin unless you're sure that the potassium is within the acceptable range. Why you want insulin? Is that because you want to decrease the glucose level? Well, this is not the main aim. The main aim is to stop lipolysis and ketogenesis. That's why you add dextrose at one point of time to the IV fluid, as that will allow us to continue insulin and get ketogenesis under control without inducing hypoglycemia. Okay. You started the patients on IV fluid, you expanded the intravascular volume, the kidney function improved as a result. That will enhance the ability of the kidney to excrete the ketoanions, right? So again, this part of keto acid anions will be excreted in the urine with sodium. Another part will be excreted in the urine with potassium. You're losing sodium, potassium, and alongside with that, water, right? Against relatively fixed amount of chloride. That will increase the concentration of chloride. Number one. Number two, the normal saline has high chloride concentration in relation to the normal, usual chloride level in the plasma, and that would also contribute a bit and increase the concentration of chloride. Okay. Now, what would happen to this part of keto acid anions? It will be taken up and metabolized by brain cells and other cells. Please note that every keto acid anion will consume one hydrogen ion in the metabolism inside the cells. Okay, I have to say that with metabolic acidosis, the ammonia genesis will be stimulated in the liver. How? Metabolic acidosis will stimulate the liver to produce glutamine. Glutamine will be taken up by the cells in the proximal tubules. It will undergo several reactions and produce ammonium. That's why they call it ammoniogenesis, and will produce bicarbonate, which is the most important product of this process. They should have called it actually bicarbonate genesis. Okay. The regenerated bicarbonate will replace the metabolized keto acid anions. Okay, now after, let's say, 8 hours into the treatment, let's take a look again on the blood tests. Bitter pH up to 7.27, bicarb is up to 16, PCO2 is well compensated, kidney function has improved significantly, sodium 140, potassium 4.5, chloride of 112. Okay, let's do the anion gap again. The anion gap will be 12. But yet I have metabolic acidosis. The bicarb is low. So why I have acidosis but with normal anion gap? It is because of increased amount of chloride. It is because of hyperchloremic metabolic acidosis. Now, what would happen in the coming few days? The ammonium will take care of the excess chloride. And the regenerated bicarbonate will replace the lost chloride with the ammonium. Okay, in few days' time, the bicarb will be back to normal. Chloride will be down to the normal range, and the anion gap, of course, will be normal. Okay, now let's talk about some facts here. The concentration of insulin required to suppress the lipolysis is only 1/10 that required for glucose uptake. That's why we see DKA more frequently with type 1 than with type 2. DKA patients will usually have high anion gap metabolic acidosis at the time of presentation. 90% of the DKA patients will reach the hyperchloremic metabolic acidosis after 8 to 20 hours into the treatment. Initiation of insulin won't shut down the ketogenesis immediately. Several hours are needed to slow the rate. Metabolism of keto acid anions usually takes many hours. Complete restoration of acid-base balance and normal electrolytes will take several days. As the ammoniogenesis increases, the keto acid anions will be largely excreted with ammonium, not with sodium, not with potassium anymore. And the lost keto acid anions with ammonium will be replaced with regenerated bicarbonate. Glucagon is not essential for ketogenesis, as DKA can still be happening after pancreatectomy. Beta hydroxybutyrate is the most abundant ketone body in DKA. The ratio between beta hydroxybutyrate and acetoacetate will rise from 1 to 1 to 3 to 1 and can reach even as high as 10 to 1. Mortality rate, if the insulin is always available and there is easy access to the hospital, is very low. It's less than 1% in young diabetic patients who are otherwise healthy. However, it can reach up to 5% in patients with comorbidities who are older than 65. The cause of mortality in adults is the precipitating factor, such as infection, MI, or other intercurrent illness, whereas the leading cause of death in children with DKA is cerebral edema. Insulin is one of the most important discoveries in the history of humanity. The first injection of insulin was given to a 14-year-old boy with type 1 diabetes mellitus in January 11, 1922, in Canada at the University of Toronto. Okay, let's move to some of the practical points now. The average fluid loss in DKA is about 3 to 6 liters. Urine dipstick would detect acetoacetate but not beta hydroxybutyrate. A negative dipstick in the context of DKA is rare. Such a condition can rarely happen if the beta hydroxybutyrate is the only ketone bodies in the urine. Blood test will detect only beta hydroxybutyrate, on the other hand, not acetoacetate. Some organizations prefer ketone blood level over the urine dipstick for the diagnosis of DKA for the following reasons. Blood level has better specificity. Providing urine sample may take few hours when the patient is drowsy at presentation or when catheterization is needed. You can't rely on the urine dipstick to monitor the response of DKA to treatment. Why? Because hydroxybutyrate will be oxidized back to acetoacetate. Since the oxidation of beta hydroxybutyrate to acetoacetate is a must during metabolism, the urine will still be significantly positive for ketones during treatment. This is misleading and will give you a false impression that DKA is not improving. Do not give insulin without checking the potassium. And if the potassium drops to less than 3.3 while you're giving insulin, please hold insulin, correct hypokalemia, then resume it. Do not give sodium bicarb infusion, if decided, before checking the potassium, because some of the infused bicarbonate will be excreted in the urine, and that's usually accompanied by cations, sodium or potassium. Unless your potassium is normal, please do not give sodium bicarb infusion. Extended lights profile, including magnesium, phosphate, calcium, should be obtained. We decrease the glucose level slowly to avoid a sudden change in the osmotic gradient and subsequent cerebral edema. You don't need to correct sodium for glucose when calculating the anion gap, as the water shift and dilutional effect will affect both sides of the equation, the sodium as well as chloride and bicarbonate. And at the end, I would say that DKA is serious and can be life-threatening and usually managed in the step-down, intermediate, or intensive care units. Now you can fly away, guys. Thank you so much for listening. Hope you found it useful, and see you soon.